Good. Thank you, and good morning, everyone. I must confess I'm actually not going to talk about research. Oh my. What I do want to talk about, and extending the analogy that Dr. Talbot established about touchdowns, I want to reflect on delay of game. There's an increasing delay between vaccines exiting the pipeline and being approved for use and their adoption into provincial programs or broader public use. And I think that's worth reflecting on. So by way of disclosure, I do research with a variety of companies. So I have received research funding, but that's irrelevant to what I'm talking about. What is relevant is the fact that I'm an infectious disease specialist, and it pains me greatly to encounter infections that I know full well could have been prevented. And that's really where I'm coming from this morning. So Canada was once a swift adopter of new vaccines. We scored some notable touchdowns in the past. Quick to adopt inactivated polio, H influenza conjugate vaccines. Across the country, provinces adopted acellular pertussis vaccines in the mid-90s, all within a year. But then things slowed down. Program delays after the NACI recommendation have averaged several years. MenC conjugate vaccine, recommendation made in 2001, and adoption by provinces skewed between 2002, Alberta, and 2005. Recommendation for pneumococcal conjugate vaccine made in 2001. Provinces took between 2002 and 2006 to make good. Varicella vaccine, it took up to 7 years for the last province to adopt it. Rotavirus vaccine, recommended in 2008, and still only half the provinces are offering it in 2014. A notable exception was HPV vaccine, which got implemented within a year by all of the provinces thanks to special federal funding to implement programs within the National Immunization Strategy. And in fact, it was another set of special funds that actually got MenC pneumococcal and varicella vaccine implemented in 2005 and beyond, or the delays relating to them would have been even longer. So that aspect of the National Immunization Strategy was really important, but it's my understanding that that aspect isn't going to be continued with the renewal of the NIS. Well, what are the contributors to the delays? The NACI statements themselves have been less timely recently because the deliberative process that they go through has been more detailed. Following the Erickson-de Walls criteria, they have to focus carefully on detailed Canadian epidemiology, modeling the impact of vaccination, systematically reviewing vaccine properties, and a host of other considerations that are relevant. And unfortunately, the evidence needed by NACI is not always available to them in a timely manner. But I'm more concerned about the post-NACI delays. There is a second committee with provincial territorial recommendation, participation, the Canadian Immunization Committee, that conducts a joint review of the program implementations. And here the distinction between NACI and CIC is very important. NACI statements identify the potential benefits to individuals receiving a new vaccine. CIC goes a step beyond that to look at what the program implementations are. That is often a lengthy deliberation, focusing particularly on cost effectiveness. And of course, the higher cost of recent vaccines has been challenging. And while it was hoped that CIC deliberating together might result in more concurrent and prompt movement to programs, that really hasn't been the case, because every province ultimately has to appeal to its ministry for funding, and that step in particular can be quite lengthy. The really important question to ask is, why are these lengthy multi-year delays accepted? And I guess the answer is, blessed are the meek, for they are us. We simply have not been used to encountering multi-year delays in accessing new vaccines. We just don't have a social mechanism by which to object, to hold our governments to account for the delays. Now, many of you are public health employees, and I can understand why you're reluctant to protest decisions or delays by your own employer. The rest of the healthcare sector is too diffused to lobby effectively, and the general public doesn't exactly jump up and down demanding new vaccines ordinarily. One has to worry about the ethics of the delay. How many cases might have been prevented during these multi-year delays with these particular vaccines? That's what's worried me. I've been on the receiving end of those cases. Who should take responsibility for failing to avoid the avoidable in the face of national recommendations? And more importantly, what can we do during such delays? And I think the most important message that I have is that we shouldn't be keeping recommendations for individuals, the POST-NACI recommendations, a secret. We shouldn't be ignoring them. If a vaccine is licensed in Canada and recommended by POST-NACI, then eligible individuals should be aware of it, and they should be able to access it for their own protection. Zoster vaccine for seniors being a good example. We have tended to think that vaccines should be offered in programs or not at all. And my argument is that's not appropriate anymore, given that we can't fund everything that we would like and as quickly as one would like. Now, physicians for some time have been under the gun by their own medical insurer to inform eligible patients of the option to protect themselves with unfunded vaccines that have been recommended for appropriate use, or they would be legally liable for the consequences should one of their patients develop a preventable infection. I'm really pleased to see that some provincial health departments have adopted a similar approach as best practice. So they include mention of unfunded vaccines in their public promotion, their websites, and in fact at the level of individual nurse counseling of individuals. And the increasing availability and participation of pharmacists in immunizations is helping for individuals to access vaccines. More available, much easier to deal with the user pay situation. On the public sector, Immunize Canada is certainly playing an increasingly important role as a provider of trusted information to the public. And more professional organizations are joining to broaden the message to niche groups such as pregnant women and the elderly. The reality is most recommended but unfunded vaccines do end up being included in public programs. So recognizing their value and supporting early use really isn't heresy. So I think we're at the point where we simply have to accept the notion that we're past the point where governments can fund every vaccine, and it's going to be necessary for people to purchase some vaccines that will be of benefit to them. The target populations for funded programs are aimed at those who can benefit most and don't include usually everyone who could benefit. So there are inevitably members of the at-risk population who could benefit but aren't included in our programs. Think HPV vaccine introduction. Adult immunizations will likely remain underfunded and despite a growing number of new vaccines. There are already niche vaccines that will be better for some patients. I'm thinking adjuvanted influenza as a current example, and that might never be funded. And of course, the immediate objection is the inequity that results from differing ability to pay as individuals. But there are potential remedies for that, one of them being the inclusion of vaccines in pharmacare programs so that the less well-off could benefit as well. So there was a workshop sponsored by the CARE organization back in 2012 that looked at this dilemma of recommended but unfunded vaccines in detail and led to a recent publication that I've mentioned here. And if you're interested in this problem, this particular article goes into much more detail on particularly the alternative funding mechanisms to make unfunded vaccines more widely available. And I'll stop there.